Good afternoon, and thank you for joining today's webinar on what everyone should know about peripheral artery disease, or PAD. A couple housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions through audio, please note the Q&A function on your screen. If you have a question that is not addressed in the presentations, please submit through the Q&A, and our presenters will answer as many questions as possible at the end. Also, today's webinar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's posted. It is now my pleasure to introduce our speakers. Dr. Kendi White is a cardiologist and vascular medicine specialist with University Hospital's Harrington Heart and Vascular Institute. She is an assistant professor at Case Western Reserve University School of Medicine. In addition, Dr. White is principal investigator of Vascular for hypertension and peripheral artery disease testing in Cleveland area barbershops. She will discuss this research study opportunity later in the presentation. Next is Dr. Chris Longenecker. He is director of the Research and Innovation Center for University Hospital's Harrington Heart and Vascular Institute and director of the HIV Cardiometabolic Risk Clinic. He is also an associate professor at Case Western Reserve University School of Medicine. Our next panelist is Dr. Heather Gornick. She is co-director of the Vascular Center and director of the Fibromuscular Dysplasia and Arterial Dissection Program of University Hospital's Harrington Heart and Vascular Institute. She is also a professor at Case Western Reserve University School of Medicine. Also with us is Dr. Mehdi Shishabor. He is co-director of the Vascular Center, director of the Interventional Cardiovascular Center, and director of the Limb Salvage and Amputation Prevention Program of University Hospital's Harrington Heart and Vascular Institute. In addition, he is professor at Case Western Reserve University School of Medicine. And finally, we are also pleased to have with us Dr. Norman Cummins. He is a vascular surgeon with University Hospital's Harrington Heart and Vascular Institute and clinical assistant professor at Case Western Reserve University School of Medicine. Welcome to all of our panelists. I will now turn it over to Dr. White, who will lead off the presentation.
Okay, well, first of all, I want to thank each of you for taking the time to tune into this webinar. I hope that you'll find something useful and you'll be able to share this knowledge with others. So what is peripheral artery disease? So that's peripheral artery disease, or PAD as we call it, is a chronic disease, meaning it develops over time where you develop plaque or blockages in your leg arteries. So this plaque blocks the passage of blood flow, which can result in poor circulation. So if you see on the schematic on your right, you have a normal artery with normal blood flow, and you have an artery with blockages, and that results in decreased blood flow in a narrowed artery. So when parts of the leg do not get enough blood due to the narrowing of the arteries from plaque, symptoms can develop. Next slide, please. So what are the symptoms of PAD? So pain in the buttocks, hips, or legs with exercise that goes away with rest. This is a classic symptom. I have patients that tell me, they ignored this because they thought it was a Charlie horse. They'd been working out and they just thought it was a muscle sprain. But it's important to know that this can be a classic symptom of PAD. Other symptoms include fatigue in the legs and not being able to walk as far as you normally could. You can also get burning or aching in the feet and toes, especially at night while lying flat. And you can get wounds or ulcers on the feet and toes as well. And in many cases, there are no symptoms at all. Next slide, please. So what are the risks of having PAD? Well, first and foremost, it greatly increases the risk of having a heart attack or stroke in the future. So if you look at the picture on the right, you see that there's blockages in the arteries to the legs, and that's peripheral artery disease, but you can also, through the same process, have blockages in the arteries to the heart, and that can lead to a heart attack. And so all of these conditions can result in poor quality of life, but I've had patients with PAD tell me one patient couldn't walk around their house at all anymore and do just the normal activities that they're used to doing. So you can imagine, in addition to being physically crippling, it can be certainly psychologically limiting and painful as well. So if untreated, this can ultimately lead to leg amputation or even death. Now, these are very serious risks, and if this was a relatively rare condition, then maybe we wouldn't be as concerned about it. But PAD is actually very common. It's important to know that it affects over 220 million people worldwide, and about 10% of the population in the U.S. over the age of 40. So in order for us to avoid getting PAD, we need to first know what sort of things can increase our risk of getting the disease in the first place. So that's what Dr. Longenecker will discuss next.
Thank you very much, Kendi, and it's great to be here today. So I'm going to talk a little bit about managing risk factors for PAD, and as a preventive cardiologist, this is something I think a lot about. There are actually a lot of different medical problems that can increase your chances of developing PAD, but I'm going to focus today on 4 key risk factors: cigarette smoking, diabetes, hypertension or high blood pressure, and hyperlipidemia or high cholesterol. So these are the 4 that you should remember today. And to lower your risk of PAD, you first have to know whether or not you have any of these conditions. So you need to go to the doctor and have your blood checked, have your blood pressure checked. And then once you know if you actually have one of these conditions, getting the appropriate treatment to manage them. And if you do not, I think you all can agree it's best to try to prevent them by keeping a healthy lifestyle, healthy diet, and exercise. So let's start with cigarette smoking. So most people with PAD are current or former smokers. And smoking is bad, we all know it's bad, but in this case, because it speeds up the process of atherosclerosis, which can lead to blocked arteries, as you can see in the picture there. And quitting may lessen your leg pain if you have PAD and prevent the disease from getting worse over time. It's interesting that PAD is actually more closely related to smoking than heart disease is. And some other noteworthy points are that secondhand smoke is also dangerous, and the effects of e-cigarettes are not known, but vaping is not entirely safe. It still delivers nicotine in the body, which can have effects on the heart and blood vessels, which we're still beginning to understand. So the best option is to not smoke or vape at all, and not be around people who smoke. And if you would like to quit smoking, you can call 1-800-QUIT-NOW or talk to your doctor, because there are lots of medications, and nicotine replacement therapy can help you quit. Next slide. We'll talk a little bit about diabetes. Diabetes mellitus causes sugar to build up in the blood. It's in fact increasingly common, especially as obesity is on the rise in the United States. And like smoking, it is actually more strongly related to PAD than heart disease. People with diabetes and PAD are at much higher risk of amputation than those without diabetes. So it's very important to treat diabetes so that you avoid the PAD complications. Type 2 diabetes can be treatable, and in some cases, with extreme diet and lifestyle intervention, can be curable. If you see on the right side of the screen, these are the things that make up an important healthy diet. And at the base is a good, healthy amount of physical activity. The American Heart Association recommends 150 minutes per week, or 30 minutes at a time for at least 5 times a week. Next slide. So finally, high blood pressure and high cholesterol, or hypertension and hyperlipidemia. High blood pressure damages arteries and increases the risk of PAD. And we know that diet and lifestyle are key to controlling blood pressure. So very important to focus on those. But unfortunately, medications are usually needed as well to reach the goal, which we consider less than 130/80. To reach this goal, I found that a home blood pressure monitor can be very helpful, because in fact, it's the blood pressures that you have at home, not the blood pressure when you come into the doctor when you may be scared or rushing in off the street, that matters most. So talk to your doctor about a home blood pressure monitor. High cholesterol in the blood can also build up in the walls of the artery and cause blockage, as you can see in the picture. And statins, as shown in the diagram there in the chart, are first-line medications to lower blood cholesterol, such that everyone with a history of PAD or heart disease and most people with diabetes should be on a statin regardless of their cholesterol level. Next slide. In order to reduce the risk of a heart attack and stroke, all patients with PAD should be on a blood-thinning medicine, and the two that are commonly used are aspirin or clopidogrel. And in some cases, another blood-thinning medicine called rivaroxaban may be added. And in summary, you can see the medical treatment and management of risk factors for PAD are shown in the chart there. Thank you. I'll introduce Dr. Gornick, who will now talk about diagnosing PAD and treatments to improve leg symptoms and quality of life.
Thank you, Dr. Longenecker, and thanks to my colleagues for organizing this symposium. So my job is to briefly mention how PAD is diagnosed and then how do we think about treating it. So in terms of the diagnosis, it really starts with a detailed medical history by your healthcare provider. And that would include what are your risk factors, as Dr. Longenecker mentioned. Have you smoked tobacco? And what are your symptoms? Then there would be a physical examination, which would include taking off the socks and shoes, looking at the feet, and also checking the pulses in the legs and feet. The next step to diagnose PAD is something called the ankle brachial index, which we'll talk about in a moment. And those are really the three things that are the cornerstone of diagnosis of PAD. It's actually a pretty simple diagnosis to make once people suspect the diagnosis. In some cases, we need to do some more advanced imaging studies, such as shown here on this slide. This is a vascular lab study where blood pressure cuffs were placed at various points along the leg and blood pressures measured at different parts of the leg to tell us about flow in different parts of the leg. This is an MRI study that showed the vessels in the lower extremities, in this case below the knee, and this is an ultrasound exam. But actually it's only in a certain percentage of cases that we need those advanced tests. In many cases, it's just the history, the physical exam, and the ABI. In terms of the medical history, Dr. White-Soloru already mentioned this, but your provider will ask you about claudication. Do your legs hurt when you walk, either your buttocks, thighs, or calves? And does the pain go away when you stop and rest, usually within 10 minutes? And if you answer yes and yes to both those questions, there's actually a high likelihood that you have PAD, and you definitely need to be checked out with the ABI or other evaluation. Other things your doctor may ask you: do you have other types of pain or problems with your legs that limit your walking? Do you get pain at rest in your legs or feet? And do you have sores on your legs and feet? Now, I mentioned this simple test called the ABI test, the ankle brachial index, and this is really the cornerstone test to diagnose PAD. We actually don't have a blood test for PAD. This is the fundamental test we do. And what that involves is, and some of you on the webinar may have already had this test done, it involves actually lying down flat and having blood pressures measured in the arms and legs, so both arms and both legs. And then we measure the pressures and we compare the blood pressures at the ankles or the legs compared to the blood pressures in the arms. And in normal, healthy people with healthy arteries, the leg blood pressures are actually the same or a little bit higher than the arm blood pressures. So that ratio is 1 or above. And in people who have PAD, that ankle brachial index is low. In terms of treatment, there's three things we want to do when we care for a patient with PAD. We want to prevent heart attacks and strokes, as previously mentioned, and that's a really important part of the care for patients with PAD. We want to protect the legs and feet, And we want to treat symptoms to improve function and quality of life as best as we can. And in terms of preventing heart attack, stroke, and amputation, as you heard, it's vital to quit all smoking, including electronic cigarettes and marijuana. You heard about blood thinning medications from Dr. Longenecker, aspirin, clopidogrel, in some cases also things like rivaroxaban. You heard about managing risk factors, statins, diet, high blood pressure, and diabetes, all vital in caring for patients with PAD. Exercise is very important. And then if you have PAD, it's very important to take care of your feet. You have to wear comfortable, well-fitting shoes to prevent sores. You have to moisturize the feet regularly and keep your toenails trimmed. You need to check your feet regularly for sores or breaks in the skin. And when you go to the doctor, make sure the doctor also takes off your socks and shoes and has you take off your socks and shoes and checks your feet. And this is especially important if you have PAD and diabetes, because as you'll hear from Dr. Shishabor, patients with both of those conditions are really at the highest risk of developing something called critical limb ischemia. And then in terms of improving function and quality of life, quitting smoking can prevent a heart attack, stroke, but also can help with leg symptoms and prevent amputation. So that's absolutely vital. We have a wonderful treatment for PAD called supervised exercise therapy, or in some cases known as exercise rehab. And this is a treatment that's actually now available to Medicare patients. And it involves going for training sessions on a treadmill guided by an exercise physiologist, often in a cardiovascular rehabilitation center. And patients do periods of walking and then rest to train the legs. And this actually has been shown to improve the total distance walked and the distance patients can walk without pain. And supervised exercise has actually been shown to be as or more effective as leg stents or bypass surgery in many cases. Finally, there's also a medicine called cilostazol that can help and lessen symptoms in some patients with PAD, but it does have some side effects, including diarrhea, headaches, and heart palpitations. So not a wonder drug. And then finally, as a segue to our next speaker, we have something called revascularization, which is improving blood flow to the lower extremities. And most patients with PAD will not need a procedure and can be managed with medications and exercise training. But some patients with severe symptoms, and especially those with something called critical limb ischemia, do need to undergo procedures to improve blood flow to the legs and feet and prevent amputation. And as you'll hear, there's been a real huge paradigm shift from open bypass surgery to more minimally invasive and endovascular procedures like angioplasty and stents for our patients. And this was a case of my colleague, Dr. Shishabor, our next speaker, a patient with blockages in the aorta and iliac arteries that had balloon angioplasty and stenting. And now I'm very pleased to introduce Dr. Shishabor, who will speak on critical limb ischemia.
Thank you so much, Dr. Gornick, and it's a pleasure to be with all of you today. And I hope everyone is healthy and looking forward to having a nice dinner. It's getting late in the evening, or a nice drink. Next slide, please. Yes, as we discussed, so we're talking about a spectrum here. So PAD, as a matter of fact, majority of the patients, as my colleagues, Dr. White and others mentioned, are actually asymptomatic. You may not even know that you have PAD. And as we advance, we have what we call Rutherford category 3, or lifestyle limiting claudication. That's the one that Dr. Gornick was mainly talking about. And now we move to the areas where we call the most advanced. We call the critical limb ischemia. And these are patients that have ulcers, gangrene, they have rest pain. They are really at risk of losing their leg. And our goal as health providers is to prevent them from getting amputated. Unfortunately, this condition mainly affects those that smoke and those that are diabetic. Others can get it too, but those two are the highest risk factors for this condition, as mentioned earlier. Next slide, please. Unfortunately, these are, and I apologize for the gross pictures, this is what CLI is. These are patients that are in significant pain. They have gangrene on their toes. But what's really important is that these are patients that are at increased risk of dying. Indeed, if you have gangrene or ulcer as a result of vascular disease, PAD, your likelihood of you being alive in 5 years is 50%. So that is why it's so important that we get to see these patients early, not only to save their leg, but also to be able to get them on the proper medication, prevent them from smoking, help them with diet, all the things that we talked about today, so that we can prolong their life and give them good quality of life. Next page, please. And the patients have a lot of comorbidities. This slide basically shows that patients are getting sicker. So the patients that I see with ulcers and gangrene, as you can see from 2003 to 2011, much more likelihood of having high blood pressure, much more obesity, much more diabetes, kidney disease, and even prior amputation. So patients are living longer, they have more comorbidities, and that is why it's so important that we control our risk factors like smoking and diet and diabetes, but also that we seek help in a timely fashion. If you have diabetes, if you know you have PAD and vascular disease, and you have a skin breakdown or an ingrown toenail, you don't want to wait. You want to immediately seek help. If you're told that you need an amputation, you want to get a second opinion. That's actually one of my pet peeves. Always get a second or third opinion and not take amputation for an answer, because there are many options that are available that can help you in 2020 and beyond. Next slide, please. Unfortunately, this condition, even though it's deadly, and even though it significantly impacts the quality of life of our patients, is way undertreated. So this was a study that was done in the United States and looked at patients in different areas of United States. If you will, where it says very high intensity regions, that would be a city where there is a lot of universities, a lot of vascular care. That would be like Cleveland, right? There are a lot of medical centers. A very low intensity region would be a place, let's say in the middle of, I don't know, Texas, or in some location where there are not a lot of universities and medical centers taking care of patients with vascular disease. And unfortunately, this study showed that if you look in the year prior to a major amputation, between 30 to 70% of those patients that got a major amputation had no vascular evaluation in the year prior to their amputation, meaning that we are undertreating. We are not aggressively evaluating patients that are at risk of losing their leg. And we know losing your leg has significant psychologic, quality of life, and morbidity. Next slide, please. And there is a lot of disparities. And I know Dr. White is also very passionate about this. And that's why she's doing this program in the barbershops and other activities that she's involved with. We know that there is a lot of disparities by geography. You can see here, we call this the tobacco belt. If you look at the colors, the darker colors indicate more amputation. Some areas, there's a lot of amputation. Other areas in Midwest, for example, we see less of it. So there's definitely a geographic variation in amputation. Ohio is somewhere in the middle. Next slide, please. And then there is racial and ethnic disparities. And this is an area that we are all passionate about, but I think Dr. White is really extremely passionate about this, and she's doing extensive research in this area, trying to impact. If you have two gentlemen walking to a hospital, both one white, one black, the person that is black is 4 times more likely to get amputated and 4 times less likely to get revascularized, even though they have the same medical condition. So we are all passionate, and I think that all of you that are on this call could be ambassadors for this. If you know of patients that are at risk of losing their leg, that have ulcers, we want to take care of those patients, and we are always available for second or third opinion to take care of patients like this. Next slide, please. And this is just an example. These are the kind of things we do. This is, for example, a patient that had 100% blockage in one of their arteries in their pelvis. You can see here, we are able to come in, pass wires through these blockages and place a stent. Sometimes we use a stent. Sometimes we use medicated balloon. Sometimes we use other devices to remove the plaque and the debris. And sometimes we offer other modalities to these patients. Next slide, please. And this is kind of my last slide. It's a little bit the busiest slide, but it just shows you the complexity of the legs. And we are focusing a lot on lower extremity vascular disease or PAD, but we have many options to treat each segment. So each area has its own options that I've shown on the right or the left. And these are different tools that we have in our armamentarium to treat these patients. Beyond these, we also have surgical and hybrid procedures. And we are fortunate we have my partner, Dr. Cummings, who can explain some of those procedures to you guys. I thank you so much for your time, and I ask Dr. Cummings to take it over here from a surgical approach. Thank you.
Hey, thank you, Mehdi. Thanks to everybody who's tuning in, and thanks to Dr. White for organizing this entire program. I was asked to talk about a surgeon's perspective of critical limb ischemia for arterial disease of the lower extremity. And I would say that our primary goal is to avoid amputation in our patients. And amputation can be performed, as you can see on the left screen. We can remove at the level of the foot, below the knee, or even above the knee. In extreme cases, even remove the entire leg up to the level of the hip. The photographs show you a typical above knee amputation and a typical below knee amputation with someone removing the staples. Next slide, please. It's really critical that we avoid amputation in as many patients as possible. Amputation is extremely challenging for patients, and it really changes their life. It's really life-altering. If you look at results in the circle on the left, it shows you that only 60% of patients have primary healing of an amputation. 10% of these patients die early, 15% go on to an above knee amputation. And if you look at the outcome after 2 years, only 40% of patients actually end up with full mobility. So it is quite a lifestyle change, and we try to avoid this as much as possible. Next slide, please. So we are often asked to provide a surgical solution to bring blood back down into the leg. So patients can lose their leg or be at risk for losing their limb due to a lack of flow. And there are two main ways that we bring blood down to the leg. One is by a surgical bypass, which essentially means that we tie a tube or connect a tube from an artery that is open, and we go down the leg to an area that is open and plug that tube back into the normal appearing artery. So that would be a conduit or tube. We can use a patient's own vein, or in some cases, we can use a prosthetic piece of graft, Gore-Tex or a polyester graft. The other main option that we have for surgery is to perform an endarterectomy. And that basically means cleaning out the plaque. And often we open up the artery, clean out the plaque, and leave a small patch on top. And I'll show you illustrations of both of these. The other option is a hybrid procedure, a combination. Do something surgically open, clean out the artery perhaps, and then combine that with an angioplasty or stent going up or down the leg. Next slide, please. So here is a typical surgical bypass of the lower leg. You can see there's an artery blockage in the artery going through the thigh, and even more blockage down through the arteries in the leg. And a piece of vein has been sutured up top where the artery is normal. It bypasses all of the disease segment and is plugged in down near the ankle. This is a typical vein bypass. It is a fairly complex, tricky, tedious operation. Next slide, please. Often requiring multiple incisions up and down the leg to remove the vein and tie off all of the branches of the vein and connect it to the artery, both proximally and distally. But this operation, although somewhat prolonged, yields fairly good results in the long term. Next slide, please. A bypass can be performed anywhere, really. And here's an illustration of a bypass going around a blocked aorta and iliac artery in the abdomen. So a prosthetic graft can be sewn to the aorta around blockages down into the groin. Okay, next slide, please. Endarterectomy is where we actually physically pull out the blocked area of plaque. And this is more appropriate for areas where there is localized disease. Commonly, this is done in the neck, And in this picture here, we've done this in the groin. There is a blockage in the femoral artery, and the plaque is being removed. And often the defect here is sutured with a piece of patch, such as not to narrow the artery when the artery is sutured closed. And finally, next slide. This is a illustration of a hybrid procedure. The artery has been patched below, where you can see over the bone where the lower red arrow is. And this patch has been combined with a stent that goes more proximally. And you could actually stent further distally as well if you wanted to, or if the patient needed that. And then next slide, please. And when we're deciding whether to perform an open operation or an endovascular operation, or how to select a procedure, one of the things we try to determine is what is the goal for that patient. And this somewhat illustrates that. There are 3 levels of perfusion, if you will. There's normal perfusion, illustrated here at 100%. There is a healing threshold, slightly under 80% in this drawing. This is arbitrary, not to be taken seriously. And then there's a level of around 40, and that is the patient's own metabolic demand. And what this indicates is that if you have perfusion below the level of your own metabolic demand, patients will spontaneously start to lose tissue, spontaneously get gangrene. So this level of perfusion is not satisfactory. But it depends where the patients start. If the patient has an injury to their limb, but their baseline perfusion is above their metabolic demand, they don't necessarily need to keep their perfusion at normal for prolonged periods of time. And this is somewhat illustrated here, where a patient on the left is starting out below his metabolic demand. He is revascularized and then goes above the healing threshold, but then develops some recurrent disease. And that path can take one of two turns. On the top, illustrated at goal with the arrow, is that the patient has healed and the perfusion remains above the metabolic demand of the foot. Whereas in the bottom section here, you can see that the perfusion, if it gets to the point where it's below the metabolic demand, that patient will go on to lose their limb without further treatment. So these are some of the things that we take into account and weigh when we're selecting a procedure. And with that, I'm going to thank you for your attention and turn it over to Dr. White.
Dr. White, I believe you're muted.
My apologies. I said that thank you, Dr. Cummins, and I'm going to talk about a topic that I'm very passionate about, which is disparities in PAD. And Dr. Shishbor did an excellent job at touching on some of that. So next slide, please. So health disparities related to PAD. I feel like disparities is tossed around a lot, but it's important that we really define it. So these are differences in the burden of disease experienced by one group over another. And health equity means that everyone has a fair chance to be as healthy as possible. So this requires removing obstacles to health such as poverty, discrimination, and lack of opportunities to improve socioeconomic status. That's critical. So if you look at this cartoon that I have here, you see one gentleman on the left who is able to reach that apple of best health possible. And you see another gentleman who's unable to reach that on his own. Sometimes you see this depicted as two individuals of the same size, but one is standing in a ditch. So, you know, it's not enough to just leave them in that ditch. It's all of our responsibility, collective responsibility, to make sure that we have programs in place to give this person a leg up, give them a fair chance to obtain their best health as possible. And so that's what programs designed to reduce health disparities, including my studies, are meant to do. So to talk specifically about why there might be disparities related to PAD, we can talk in terms of the actual risk factors for PAD and how it affects minorities. And to be honest, the burden falls on African Americans most specifically. So cigarette smoking Blacks are less likely to quit compared to whites, even though there are similar rates of smoking in both groups. When we look at diabetes, Blacks and Hispanics have much more likely to have this condition, okay? And hypertension, Blacks are much more likely to have this than other groups. Estimates about 45% of Blacks can have this condition, which is a lot. So hyperlipidemia, although Blacks are less likely to have this than whites, they're also less likely to be treated when they do present with that. So it's important to know about health care delivery disparities as well. And then when we think about things such as poor socioeconomic status and lower education, at least in terms of PAD, there's been several studies to show that the more below the level of poverty, the more wealth that you have, the less likely you will have PAD. And similarly, with each education obtained, high school diploma, college education, graduate, the lower the rates of PAD. But I lump them together because I think, honestly, this is most likely related to socioeconomic status and opportunities. Another important component of education that we don't think about as much is just awareness. When it comes to awareness of PAD, only about 25% of all individuals know what PAD is and are able to define it. Now, when it comes to knowing that PAD can lead to limb amputation, that number drops to about 15%. But when you define it only among African Americans, the number drops to a critical 6%. And so I think that, in my eyes, that's a huge disparity and something that we can all address. Next slide, please. So, so disparities and risk factors, as I mentioned, it causes PAD to overwhelmingly affect African Americans more than other racial groups. So in this chart that I'm showing on the right, you have men at the top, and this is showing the prevalence or the rate of PAD in the population, and then you have women below that. And the solid black line represents African Americans. So you can see with the men, African Americans are at least twice as likely to have PAD as all other ethnic groups, and actually at the highest age group, they're 3 times more likely. And then for women, women are also twice as likely, African American women are also twice as likely to have it, but so are Hispanic women. That's the dashed line you see there. And that's significantly higher than the other groups. And then as Dr. Shishabor touched on, African Americans are 2 to 4 times more likely, depending on the study you're reading, to receive amputation. And as a result, it's not surprising that they have higher rates of death due to PAD. Next slide, please. So, you know, a part of the study that I'm doing is to look to see, can we educate people about PAD, particularly the people most at risk, and can that lead to a chance to improve their health outcomes and ultimately lower the risk of heart attack, stroke, and losing their limbs? So as a part of that, I'm starting screening for ankle brachial index, as Dr. Gornick explained, the diagnostic tool we use to diagnose PAD, as well as diabetes and cholesterol screening in local barbershops. And this study is for those highest at risk, that is African American men aged 40 years and up. So if you're interested or you know someone who could be interested or could benefit from this, please contact me directly at the number listed there. And with that, I want to thank all of our panelists, Dr. Longenecker, Dr. Gornick, Dr. Shishabor, and Dr. Cummins for being a part of this. And I hope that all of you in the audience found this enlightening and empowering. And with that, we will take questions. So the first question that I see here is venous stasis dermatitis related to PAD. Dr. Gornick, would you like to touch on that?
Sure, it's a really good question and it comes up a lot. Venous stasis is actually also a very common vascular disease, but it is a disease of the veins, whereas PAD is a disease of the arteries. So they really are not related. Sometimes patients can actually be so unlucky to have both venous and arterial disease, but they really are separate disease processes.
Thank you. And I want to remind everyone, if you have a question, feel free to type it in the question and answer box, and we will read it. The next question, can you have PAD in hands, arms, as well as legs? And I can answer that. So PAD can affect, in theory, any artery of the body. Usually when we use the term, we're referring to the legs, but certainly it can affect the arms, and it can cause symptoms, particularly when you're, using and exercising the arms. This is probably definitely more rare, but that can occur. In addition, more commonly, you can have blockages in the arteries of the neck or carotid arteries, and those can cause problems, particularly if the blockage gets tight enough to limit blood flow to the brain, and that could lead to stroke. So that's something that also would need to be addressed with medication, revascularization, or possibly surgery. So, good question. The next question I see here is, can you still have PAD if it has been more than 40 years since you quit smoking? Dr. Longenecker, do you want to address that?
Sure. Of course, the longer it's been since you've stopped smoking, the better, and so your risk is lower. But it is still possible to get PAD, and so you want to do all the other things that you can do to prevent it. Eat well, exercise, make sure you're going to your doctor to check your sugar levels and that sort of thing. But your risk is lower if you quit.
Thank you. This next question says, does a stress test show PAD? And I'm guessing you mean a cardiac stress test, or I'm not sure if that means the exercise ABI stress test, but Dr. Shishabor, did you want to address that?
Sure, I can comment on that. Typically when people have claudication or symptomatic PAD, remember the majority of the patients have no symptoms, right? But the people that have symptom, they usually have the symptom while they're walking or exercising. In order to be able to understand what the blood flow to their leg is, during walking, we typically do what we call an exercise ABI or PVR. And that's basically, we do the test at rest while they're laying on bed. And then we ask them to walk on a treadmill, or sometimes we do toe raises, but I think the one that is probably more accurate is having patients walk on a treadmill. It's not as vigorous as doing an exercise stress test for the heart, but it's reasonable. And then we check their blood flow to their legs and their arms, as Dr. Gornick mentioned earlier, and see what the blood flow is during the time when they have their symptoms or when they're walking. And so yes, we use exercise to assess blood flow to the legs. And to me, I think that's the best correlate, because that tells us as physicians what the blood flow to the legs are when the patient has their symptoms. Because if we just do it at rest, you may not get the true sense as to what the blood flow is when folks are having pain in their calf or when they are having symptoms.
Great, thank you. And then there's another question here. Are varicose veins related to PAD? Dr. Gornick, do you have any thoughts on that?
Well, I think similar to the other question, I think they are not directly related. I think there's been some epidemiologic studies that maybe, I won't even go there, that maybe if you have more of one, you might have less of the other, but I think in the end, they probably are separate problems. Disease of the arteries, PAD, and then the most common vein diseases are varicose veins, blood clots, and the venous stasis.
Perfect. Well, if no other questions, I want to thank each of you for tuning in, and I hope this was insightful. Oh, one more question. I have had stenting in my leg, and over time, my right leg began to be aching during walking. As I understand from this panel, continuing to exercise and walking can improve circulation in the leg. Also, please talk about the Medicare-approved program for improved PAD symptoms through exercise. So I guess the first part about improving circulation in the leg, Dr. Cummins, are you still with us? Okay, so
Yeah, I'm
Dr.
still here. I'm still
Okay,
here.
did you want to
Sure.
address that?
I can handle that. So, if you've had a stent before in your leg, you should still have a vascular specialist, and you might want to recontact or reconnect with that individual. We typically follow our patients forever once they've had a vascular intervention. So I think to tell you to ignore it and just keep walking might be a mistake, but that should be evaluated by your vascular provider. I will say that it is true that most patients who have claudication can exercise that leg, and that does improve the leg's ability to tolerate that level of ischemia. And that ties in with the supervised exercise therapy as a covered benefit, much like physical therapy would be prior to undergoing back surgery or a hip operation. You could undergo some physical therapy, which is supervised exercise therapy, in conjunction with controlling your risk factors, stopping smoking, controlling cholesterol, etc.
Great, thank you. Dr. Cornick, do you want to touch briefly on the Medicare approved program for supervised exercise therapy?
Yeah, this was like an exciting big win in the vascular community a few years ago because we had been pushing for this for years. So as folks on the webinar may know, there is approved treatment called cardiac rehabilitation after you have a heart attack or have a heart stent or surgery, or if you have angina. And a lot of studies have shown that supervised exercise rehab, supervised exercise training in a facility like a cardiac rehab can actually, as mentioned, help patients walk further without pain and be able to walk further without stopping. And this is now approved by Medicare. It is covered by Medicare as well as a number of other insurance companies. And we at UH actually have a wonderful network of cardiovascular rehab facilities throughout our health system. And I'm actually told that all of them can do a PAD rehab program. And I just wanted to add on to what Dr. Cummins mentioned about having procedures plus having exercise. And actually there is some emerging research that the combination of the revascularization plus the supervised exercise may give even more synergistic benefits to patients in terms of their function and quality of life.
Great, thank you. When put on Plavix, will I have to remain on it for the rest of my life? Dr. Shishabor, what are your thoughts on that?
Yep, that's a good question. We prescribe these blood thinning medications for a couple of reasons. Remember, if you have vascular disease, as Dr. Longenecker mentioned, you need to be on some kind of an antiplatelet therapy. So aspirin and Plavix are considered antiplatelet therapy. We typically prescribe one of these for you, either aspirin alone or Plavix alone. There is some controversy. Some of us like Plavix a little bit better, but a lot of people put their patients on aspirin. I think either is okay. At least the guidelines give both of them similar recommendation. If you get a stent or you have a procedure, you have a stent, some kind of a revascularization, then typically what happens, we put you on aspirin and Plavix, the two of them together for a period of time. Usually is somewhere between 1 month to 6 months. And after that, I typically change my patients back to one of them, either aspirin or Plavix, depending on a few factors. And then the third scenario is that you have other indications. Let's say you're a patient that have had a stent in the heart, but you also, as Dr. Gornick mentioned earlier, you have the bad luck of having both heart disease and vascular disease. In those situations, obviously, you are taking your Plavix and aspirin for the heart, but you will also get the benefit for the legs and for your PAD. So those are the three scenarios around aspirin and Plavix.
Great, thank you. Here's another question that was sent previously. Are there any nutritional supplements or foods that help with PAD? Dr. Longenecker, you want to talk about any nutritional foods that would help?
I think the most important is to just emphasize a healthy diet, plenty of fiber and fresh fruits, vegetables, that sort of thing. You know, there is some research on fish oils and specialized purified sorts of fish oils that may have benefit in reducing the risk of heart attack and stroke in patients with PAD. That's something we're trying to do. So other than that, I don't know that there's a lot of evidence for other herbal supplements.
Thank you. There's a question here. If no other symptoms exist, how do you differentiate between PAD or restless leg syndrome with the pain and tingling at rest? So with PAD, like we talked about, there's several different symptoms it can present with. Certainly it's classical if it develops the pain with walking that improves with rest. By the time it progresses to just pain at rest, that can be a sign of critical limb ischemia, and presumably you would have some other symptoms prior. But the tingling that occurs with the restless leg syndrome, my understanding is typically kind of related to the nerves and often occurs at night. So you obviously need to get it checked out by a physician so that they can make the diagnosis. But usually after doing the appropriate testing, it can be easy to differentiate one from the other. Another question, is PAD genetic? My dad had it. Will I or will my children? Dr. Gornick, any thoughts on that?
Yeah, actually some colleagues, I believe at Mayo Clinic, have done some work on that, and family history is a risk factor for PAD, although my understanding is that the specific genetic mechanisms are poorly understood. But family history is a risk factor for PAD. And then the other thing is risk factors tend to run in families. So I think if there's a lot of family members who smoke, that often is passed on to generations. So yes, there are genetic factors. We don't know exactly what they are, as well as environmental factors.
Thank you. The next one says, I have PAD and experience pain in my leg when walking, so I use a recumbent bike for exercise. Should I push through the pain when exercising? Will exercise create new blood veins around the partially blocked area in the leg? I think it's important to distinguish between the veins and the arteries. So what we're talking about is the arteries that can get blocked, and the veins actually are not particularly affected at all by this condition. So exercising, we don't fully understand all of the ways that it actually leads to improved symptoms, but I guess the simplified version would be to think of it as creating sort of collateral circulation, or helping the other arteries sort of provide blood to the area of muscle that was deprived by blood from that blocked area. So that's why exercising can be really good. That being said, pushing through the pain, I think if you're having pain, that's a symbol from your body that something's wrong. So, you know, usually with the supervised exercise therapy, they get you to the point where you have that, but then you back off and until the pain goes away before you start exercising again. But Dr. Gornick, did you want to add anything to that? Okay. And then lastly, we'll exercise. Okay, so lastly is swelling in the ankles a symptom of PAD? I think we kind of addressed it a little bit with this, but swelling in the ankles can be from a lot of different things. Typically, we think of more the veins causing problems, or even the lymphatic systems causing problems, and it's not typically a sign of PAD actually. Having cool or pale foot, that can be a sign that you're not getting enough blood flow to that foot. So then the last one here says circulation testing opportunities show up often. 5 tests for approximately $150. PAD test is one of 5 tests. I'm not sure what this is in reference to. So if no other questions, I think we'll end it here. And I, again, want to just thank everyone for attending and give a big thanks to our panelists for participating.